All right. So what Kim and the gang asked me to share with y'all is a little bit about this ET3 model, and I'm sure that most people have heard about it. If not, it's a Medicare fee for service program that changes how ambulance services are paid, and it allows ambulance services to get paid for things like transport to alternate destinations, treatment in place in various variations of that per se. But the interesting thing, and I want to make sure we say it up front, is that although this is a Medicare program and specifically a Medicare fee for service program, as opposed to managed Medicaid, and we'll go over that a little bit. This is not just limited to Medicare patients. So if you want to go talk to Blue Cross Blue Shield of Colorado or Anthem or United Healthcare, whatever, we are finding that many payers, not just Medicare, are interested in this model. And we'll sort of explain why as we go through it. So I want to make sure that we say that in the beginning, in case I forget to say it 5 or 6 more times as we go, but that's just important. Just because we talk about ET3, we're going to talk about the concept of emergency triage, treatment, transport, not necessarily just the official Medicare sponsored ET3 program. So we're going to talk a little bit about why we applied for this program and a little bit about the application process. We're going to spend a little bit of time talking about the implementation process. And even though we've implemented, we learn every day that there are things that we need to do to change processes, change culture, et cetera, et cetera, et cetera. I want to talk about the impacts of the model on the system, because a lot of people always ask, well, if you're going to do nurse practitioners in the field or telehealth or different things like that, it could have a relatively profound impact on the system. And I'll show you how we measure some of that. Talk about the compensation, how we're getting paid, and about the future, and really where we think this is going. Some of it will be, well, actually, most of it will be financial, but also some patient experience. And just so you guys don't get totally bored, and because this community is in Colorado, and I think we did this with different ones when I was there last time. I think, Kim, it was probably, seems like a decade ago perhaps, but actually doing this face to face. But there's this little, and I'm sorry, this is an example of how we do PPE in Texas, right? So I am in Texas, and we don't stop horseback riding for anything. Even if we have to wear PPE, we do that because we're going to keep horseback riding. But this community, I think, is near you, and some of you may be familiar with this group. And this is Indian Hills community, and they put out these fun signs all the time. And I get emailed from friends all the time, and these are hilarious. To the thief who stole my glasses, I will find you. I have contacts. Hilarious. I don't know who this person is, but they're worth their weight in gold. Maybe they do the Geico commercials too. Who knows? Man injured in bizarre peekaboo accident. He's in ICU. Yeah, pretty clever. Just a quick overview of MedStar. We are a little bit unique for those of you that aren't familiar with our system. We are a public utility model on the cultured side of the Metroplex. The official name for MedStar is the Metropolitan Area EMS Authority. That is way too many letters to put on the side of an ambulance. So our trade name, if you will, is MedStar. We are formed through an interlocal agreement between 15 different cities, which includes the city of Fort Worth and then 14 suburban cities. As you can see some of the stats there, it's a relatively busy system. We do not receive any tax dollars, which started in 2010. We were tax subsidized until 2010. We did some things to change revenue and started doing things like mobile integrated healthcare and community paramedicine and different things, and eliminated the need for subsidy. Our medical oversight is independent, and it's a board that's established by that interlocal agreement between the jurisdictions. That Emergency Physicians Advisory Board helps guide protocols. The Office of the Medical Director, which is currently 1 full-time, 2 part-time medical directors, and a staff of 13, does all of the QA training, credentialing, all that sort of stuff. So it is a very clinically focused system with really some incredible research and outcomes and things like that. So just a lot of fun. All right, so ET3. We, and Kim has been part of this, and Tim Dienst from your area and Bruce Evans from the folks in Colorado have for years been bending Medicare's ear, and every payer who will listen, that the economic model for EMS is just stupid. You only pay us to transport a patient to the hospital. So you are financially incentivizing us to spend your money. And those conversations, by and large, certainly at the federal level, at the CMS level, fell on deaf ears. And that's probably for two reasons. One, the statute that created Medicare specifically stated that ambulance transportation was the Medicare benefit. And we had heard for years that, hey, transportation is the benefit, not treatment. Therefore, you're a supplier of transportation and we're going to pay for the transportation. That's all we're going to pay for, fine, whatever. But also, we are a very, 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 very small part of the healthcare spend for Medicare. And we often refer to it as we are budget dust in terms of Medicare and Medicaid. But we also told people, hey, the payment to us might be 1 cent on the dollar, but we literally drive 25% of the spend because of convincing all those people to go to the ER just so we can get paid, et cetera, et cetera. So we wanted to be part of, when it was finally announced that that Medicare was going to do this ET3 model. And I'll tell you a quick inside story. So this occurred in earnest around 2018. And in 2018, the Center for Medicare and Medicaid Innovation, CMMI, got a new director. And that director was Adam Bowler. And Adam came from Landmark Health. He was the founder of Landmark Health. They were an innovative, home-based healthcare provider. And he had a lot of connections. And he was tapped by the Trump administration to become the director of CMMI. And during his very early days in the CMMI, I think it was actually the first month, they were in DC and he was getting into his vehicle with a couple of his staffers, and a DC fire ambulance went by, lights and siren, transporting a patient. And one of his staffers said, hey, Adam, by the way, did you know that ambulance service is only paid for if they transport to an emergency department? And Adam turned to his staffer and said, why would we do that? Because it's just, he did the math, has been in the healthcare industry before. And lo and behold, within a year, the ET3 program was launched. We and others had helped CMS develop the model, and at least somebody was listening. And actually, CMS came to MedStar for a couple of days with some folks to see some of the stuff that we were doing and ride on an ambulance and do that kind of stuff. So it was really kind of fun. But when the application process came out, we said, okay, we want to be part of the solution. And plus, we figured we were sort of required to because we helped build the model. So to not apply would seem kind of weird. But we did want to be part of that solution. And EMS is often this triumphant, if you will, not triumphant, but triumphant role of healthcare, public health, public safety. And we sort of sit in that sweet spot in the middle. And we think that this ET3 thing, 911 calls, navigation, really is consistent with what we often say we are, is we're part of each of those three main things. And we also know that healthcare in general and the payers in general are really pushing value-based healthcare and only paying for value instead of just paying for procedures, et cetera. And we felt that by doing this, we could help prove that EMS can provide more value than just a mileage fee, and putting a little Uber label on our windshield, maybe even lighted, and just being transportation. We also did the math, and we knew that in 2019, a lot of our Medicaid patients AMA'd. And if we could turn even just straight up the patients who are still going to AMA, if we could make those AMA patients reimbursable through Medicare, because we did telehealth, because we had a provider on scene, whatever it was, that the revenue increase without even really doing anything special was pretty significant. So you can see the number here, and this is from our data. So currently Medicare pays for a terminated resuscitative effort in the field, right? And everybody knows that. So when you respond to a cardiac arrest, you attempt resuscitation and you terminate resuscitation in the field, you can bill Medicare for that, and they reimburse you for that. They reimburse at the BLS emergency rate, whatever, at least they reimburse something. So for us, our average reimbursement for a terminated code was $348. If they paid that same $348 for every AMA, it was a $1.3 million revenue stream to us that we currently don't really get anything for. because Medicare doesn't cover it and the patients don't want to pay. So we collect, like, even though we bill for a non-transport, we collect like $56, right? It's just, which makes it not even worth it. So we thought it was good to be part of it. It was going to increase our revenue stream. Little did we know we were going to really need those dollars when the coronavirus hit, because call volume tanked and everybody lived through that process. So we applied, and the application process was kind of a bear, but we did it. And just so that you know some of the numbers, Medicare was hoping to approve about 500 ambulance agencies across the country for the ET3 model payment. And when the application period closed, they got about 250, because it was an arduous process and a lot of agencies didn't want to do it, whatever, that's fine. Of the 250, only 180, I'm sorry, of the 250 applications, about 205 were actually approved. Then from the 205, about 184 actually signed the participation agreement with Medicare to be an ET3 model participant. Now, interestingly, of those 184 signed ET3 model participants, as part of that agreement, you had to agree to launch your ET3 model program by 1/1/22. So by January 1st of 2022, your ET3 program had to be launched. And we all signed the participation agreements in the beginning of 20. And that had been pushed back, right? So coronavirus sort of changed things, and it was a moving target. But the bottom line is that the drop dead date for implementing your ET3 model program is 1/1/22. Of the 184, only 27 have launched. And there's all sorts of reasons for that. Some of them legit, some of them maybe not so legit. Bottom line is that we're one of the 27, and it's tough. It's a bugger, because one of the big issues with the ET3 model under the Medicare ET3 model is the primary intervention is transport to an alternate destination. So think about your local community. And even if you had urgent cares, even if you have an FQHC, even if you have some other potential destinations other than an emergency department for your 911 patients, if you had them in 2019, you lost them in 2020 because of COVID. And we did. So we had signed 2 urgent care groups to be a partner with us in the ET3 model. Those 2 urgent care groups had 14 different urgent cares in our community, and they were willing. They said, yep, and here's, we're going to paint ambulance and all this sort of stuff. They were good to go. June of 2020, they notified us they're out because they've got lines around the corner. Half of their nursing staff got reassigned to hospital duties because of hospital issues. So we lost all but one of our urgent cares. So you have to provide transport to an alternate destination as the primary intervention for an ET3 model for the Medicare program. And many places can't do that right now. The treatment in place through telehealth or treatment in place through a practitioner on scene is an optional intervention. And because of that, places that can't find an alternate destination, why bother do treatment in place? Because if you don't have an alternate destination that you can transport to, you don't meet the requirements. We'll talk more about that later. Kim, if I forget to mention the recent CMS decision regarding transport to alternate destinations, remind me at the end as part of the Q&A. So we did. We applied, we got approved, signed the participation agreement, and then we started the process. Now, the first thing that we did was make sure that through this entire process, we were communicating with our workforce that the model is out, we're applying for it, here's why we are applying. This is the value that it's going to bring to you. It's going to add up to $1.3 million additional revenue, which allows us to adjust pay rates, which allows us to get new equipment, all the things that you typically hear, because really the bottom line is that it was an economic model. And then secondarily, we told them pretty clearly that, you've told us, you guys in the field have told us for years that you would love the ability to tell Kim that he does not need to go to the emergency room. Yes, I know you called 911 for your infected toe. Gosh, I feel really bad for you, but you don't need to go to the ER. Let's do something different for you, especially in communities where you've got problems with ambulance drop times and all that sort of stuff. So we're giving you that ability. You now, for the first time in many cases, your career, you can initiate, sorry, jets going overhead. Our office is near a air station. So we get an air show every day. It's awesome. So you get that opportunity and you can really make those decisions. So there was a lot of excitement building. We also knew that we needed to keep it simple because field EMTs and paramedics don't do complicated well. And it had to be very simple. The telehealth, we're doing ours through a telehealth application. So you just have to make sure that it's easy, it's paramedic proof, it's EMT proof, and something they can understand, including the alternate destinations. Make sure that what we did was we did an online education. Because we didn't want to bring everybody in, figure 400 field providers and you got to do mandatory training. It means like 25 different classes that you got to do. So we set up an online education module, but in the online education, we included the why. And you can see here a screenshot from the video with our medical director, Dr. Vithalani, who is phenomenal. He led off that discussion and said, here's why we're doing it. It's patient-centric, it's clinically appropriate, blah, blah, blah. And oh, by the way, it helps our revenue stream. So we put the clinical medicine first and the ability of the paramedics and the EMTs to do it, et cetera, et cetera. We did a short cycle test. So we knew we got approved. We knew that the implementation was being delayed a little bit, but we also knew that the process we needed to test. So in October of 2020, October of 2020, we pilot tested this with a telehealth provider, the one that we were going to use for the ET3 program, made it optional. It was for the patients that were AMAing because we didn't want people to start talking patients out of going to the hospital yet because we weren't getting reimbursed for that. We also added a little bit of a difference in how the field providers triage patients in the field, and that is we added a economic triage component. And some of you online or in the room are thinking, oh my God, we don't ask insurance. We tell our paramedics and our EMTs, don't talk about payment, don't talk about insurance. Well, welcome to healthcare. And we've said we are healthcare providers. And in the beginning, this model is only going to be available for Medicare patients. And so therefore, one of your questions for your patient before you decide whether or not you're going to offer them an ET3 model intervention is, who is your insurer? Who's your payer? If it's not Medicare, you don't offer it. If it is Medicare, you can offer it. And that's actually, as you can see here on the screen, written right into the medical directive. So the medical directive that enables field EMTs and paramedics in our system to offer the patient dispositions other than transport to an emergency department currently only applies to Medicare patients. And that's okay. And people were okay with that. We thought we'd get more pushback. We didn't. And literally, I go on calls all the time, and I love hearing a paramedic say, so Kim, who's your insurer? Well, I've got Aetna, commercial through work. Okay, we're going to the ER. What hospital would you like to go to? It's just, well, I've got Medicare. Hey, we've got this great option for you. Would you like to, blah, blah, blah. It's nice to really hear people understanding that they are more part of the healthcare system. And for those of you online or in the audience that are thinking, it's not fair or it's not ethical to have different treatment options available to people based on their payer source, the healthcare system in the United States has done that for 100 years, and it's no problem. The reality is uninsured get different care than commercially insured, and that Medicaid patients have different available options to them than Medicare patients. It's just the way that it is. Admit it and move on and build your system around how our healthcare system works. The other thing that we realized through this process is that it's going to take longer than you think, and you cannot over communicate. And we'll give some examples of that and how we kind of do that. The next thing that we needed to do is to make sure that we communicated the goals of the program when we did the team member education. Make sure it's very clear, why are we doing it? What are the goals? It's patient-centric, it's things that you've wanted to do, and just make sure that even through the training, we did it all online initially. We did recently follow up with some face-to-face training that they understand the why. We talked about simplicity. So when we vetted 5 different telehealth providers, we did a number of different ways to vet them. First was our medical director. Who is our medical direction team comfortable with? They interviewed 5 different providers, and some were local, some were national. Second was, what is the interface like? Is the app easy. Because if the app is not easy, or if there isn't even an app and you have to go through a website that they have to access on their little smart device in their hand in the house, it's not going to happen. So we did test every one of these for both clinical efficacy, medical director comfort, but then most importantly, the technological interface to make sure that it was an interface process that the crews would be willing to do because it's relatively simple. And this is the one that we have. It's called Mobile Medicine through IES, which is our telehealth provider. IES is a local independent practice physician group. They're contracted, they're an LLC that contracts, believe it or not, with several of our emergency departments to staff the ERs. So many of the physicians that the crews are talking to on the telehealth application are docs that they see in the ER pretty regularly. So there's some familiarity there and vice versa. Several of the docs are also EMS medical directors for other EMS agencies around the region. So they understand paramedics and they understand EMTs and protocols and scope of practice, and which there really isn't one in Texas, by the way, but which really does help. But this is an example of some of the screens on our smart devices. And it's literally bada bing, bada boom, couple of clicks and acknowledge a couple of consent things for the patient, and you get a doc online. It's very, very simple. We created field guides, both electronic and printed, and you'll see examples of that. But there's a little flip guide that's in every ambulance and every first in bag, laminated 5 or 6 little cards that kind of walks them through this process. And you'll notice here that it does actually say Medicare patients only, and then all the different other criteria. We printed little cards that go on their Prox card lanyards. So it has the eligibility and then how to do it. Here's the behavioral health, here's the dispatch health appointment hotline, here's the mobile medicine access in case you get logged out, here's the backup line in case you get, logged out and you can't get anybody on the line, and you just call them on the phone, that's fine. And it is hilarious. Everybody got these when we first launched the program. We give them to every new hire academy, and we still get phone calls from crews on the scene of a call. It says, hey, what's the number for MHMR? What's the number for dispatch health? What was the backup information for, well, I lost the video, so I need to call the doc. And we'll literally say to them over the phone, do you have your cheat card with you on your lanyard? Oh, that's right. I'm so sorry. And they pull it out. But it's something that you just need to work through. But just, again, the point here is make it really easy for the field providers. Then, I don't know how many of you guys may use this paramedic protocol provider. It's an online app, or it's an app that you can put onto smart devices, etc. And you'll notice that right in the Fort Worth tab here, and I apologize for not looking at the screen because I'm looking at my other so I can see where my mouse is. We put the ET3 information directly into the paramedic protocol provider app. And this app is on all their smart devices that are assigned to the truck, it's on the home screen. So if they forget something or they have a question, they literally can open that app really quick and it's right there. And they can click on the ET Quick Reference Guide. Yeah, was Medicaid part of this? I can't remember. Oh, no, they're not. Do we call dispatch health to make the appointment, or do we just leave the number with the patient? So it's all built in and it makes it very simple for them. So they've got that. Then we also do periodic updates, and it's actually weekly, usually midweek because it's slower. And we mine, and you'll see how we mine the ET3 data, but we highlight crews and crews that have done a great job with an ET3 model intervention, as well as providing some programmatic updates periodically if there's a new thing or a new way to access somebody or a new payer that's been added to the model, et cetera. But people really like seeing their name come out and say, hey, yeah, Robbie did a really great job on this call. And then Austin had this other case that was really pretty exciting. And it was a telehealth behavioral health intervention that we did, and didn't have to take the patient to the ER. We went right to the 10th floor, which is a psych unit, and PD took them. And the beauty of doing that type of continual education is everyone who reads these scenarios says to themselves, I had a scenario like that last week or 2 weeks ago, whatever it was, and I didn't realize I could do this, and that would be a good so it really helps with showing the field providers it's great for the patients, it's great for MedStar, and it's great for you guys because the task time on these calls are lower than if you have to take them to the emergency department or whatever the case might be. And plus, they like seeing their name going out in an organization-wide email, getting a kudos for doing a good job on an ET3 model intervention. All right, let's look at another couple of fun Indian Hill signs. New CBD infused toilet paper. Now everyone can calm their butt down. Thought that was pretty clever. Cold, go stand in the corner. It's 90 degrees. People were freaking out here this morning because at 6 o'clock this morning, it was 53 degrees outside. And it's like one of the coldest mornings that we've had in a long time. And we're like, oh my gosh, go to Colorado. It's, they have snow there. Okay, so impacts on the system. We said we're going to talk about that a little bit. First and foremost, is it really energized the workforce? And like with most things, there were some that are just like, it's a pain in the ass, I'm not doing it, whatever. But for the most part, it really did energize the workforce. We have a history of doing innovative things, and the employees really dig that. They like being the first or the biggest or the whatever doing these types of programs. So, and they like to be able to recommend things to the patients that they've never been able to recommend before. I think you can see your own doctor. Let's, get a second opinion and see if we can just get you over to your doctor, or I can have somebody come to your house and do the sutures that you need on your foot instead of taking to the emergency room. Would that be better for you? Or would you like that? Not, oh my God, they can come to my house. That'd be awesome. So that, and they get a lot of, I don't want to, we use the term pride, but they feel good about themselves because, hey, and we hear it, hey, we're only one of 27 agencies in the country that are actually doing this, and we're the largest, and it's, blah, blah, blah. The financial screening we thought was going to be a hurdle. It really wasn't. And people have done a really good job, and they're documenting pretty well. And people sort of got nervous about task times. One of the performance criteria for their performance reviews is their task times. And people were freaking out because they're like, oh, an AMA typically only takes me a few minutes. Now I got to do this telehealth thing, and it's going to add, 30 minutes to my task times, and I'm going to get dinged on my performance review for doing this thing. And it's really not. And we send out that information to them every week to show them what the impact on the task times has been, and all that sort of stuff. So we continually share that information with them. There was a bit of a learning curve, as you can probably imagine. So think of your agency, and if you were to implement a pretty significant change, it's going to be slow at start, and some people aren't going to do it. Some people are going to forget, and we expected that. But through continuous reminders and some highlights, kind of get over that and reminding them of the payment impact, because we share that information with them as well, and that does help the revenue of the organization. And we also offer an incentive program, and for the last decade, maybe longer, our folks have, at the end of the year, if we meet budget performance and exceed our budget expectations, we share some of that additional with our employees, every employee, from the receptionist to the CEO, and they get a percentage of that additional money. And we said, okay, remember, and by the way, we do that right near Christmas, which is really important, and because it also coincides with our fiscal year. So we remind them, hey, if we have higher retained earnings at the end of our, and we don't make profits, retained earnings, because we're a governmental agency, then we have more dollars available for incentive payments. So that's sort of the big part of that. Now, we also remind them, make sure that you're not doing it on non-Medicare patients, because if you have a patient that you would have normally transported to the hospital, and that patient is a United Healthcare commercially insured patient, and you offer this option to them, and you don't transport where you normally would have transported, and now you don't, and we bill United for that, they're not paying for it because they haven't agreed to pay for it yet. So don't do it, because United pays us on average $1,300 every time we take somebody to the hospital. And if you don't take them to the hospital, we're not going to get that revenue. So please don't do it. And people understand that. And that's part of the being honest with folks about how you implement these types of models. So what have been the outcomes so far? So we do some pretty significant data mining because we want to measure the impact on the system. And you'll notice that, again, we launched April 5th. So as of November 7th, just a few weeks ago, or 2 weeks ago now, or a week ago, our overall emergency response volume for Medicare patients was 15,885. And I'm sure that doesn't surprise anybody. It's, about 36% of our overall call volume. We break this out for the employees because they forget that there are people under 65 that have Medicare. So just because somebody's 10 or 20 doesn't mean that they don't have Medicare. So still ask the question, who's your payer? So you can see that about 27% of the Medicare patients are under 65 because they have significant medical issues. 86% of those patients were transported, not 10% AMA'd. They did a telehealth intervention on 227 patients. Now, I will share with you that in order to be eligible for an alternate disposition, whether it be transport to an alternate destination or treatment in place, the crew has to engage a telehealth provider. We have a lot of field providers, and Dr. Vithalani appropriately was very concerned about trying to train 350 field providers in the critical decision making about what could safely go to an urgent care, what could safely stay at home. So he really wanted to make sure that regardless of the disposition, that telehealth was involved. And we had a telehealth provider that was willing to do that. So even if you're going to offer an alternate destination, you have to do telehealth in our system. And several systems are doing it that way just because it's a little safer and it helps to some extent. So notice that they used our medical telemedicine program 227 times. They used our MHMR. I'm sorry, they used our behavioral health telehealth intervention twice, and that's currently increasing. And we really want that to increase because we have a lot of behavioral health patients. Of those, 40 patients got transported to the hospital, 38 went to the ED, 2 went to urgent cares, but 140 or 62% of the total IES telehealth interventions were treatment in place. And that's what we're seeing across the country from almost every ET3 model participant that is doing this. The vast majority of the patients that are getting a telehealth or getting an ET3 intervention are treatment in place because they really don't need to go anywhere. Now, in our system, Dispatch Health, and you guys are probably familiar with Dispatch Health because they started in Colorado and South Metro has used them, and I think others are using them. They are a in-home urgent care. They send a PA or an NP with a medical assistant in the vehicle to do home visits. They can do it subscription-based. They have all sorts of different models. They are a partner of ours in this program. And if the patient needs urgent care, we don't, because we don't have a lot of urgent cares that we can transport to, we offer the patient in-home urgent care. So they need suturing, they need x-rays, they need an IV infusion of something, or they need medications or something like that. We make a Dispatch Health referral and call and make an appointment for Dispatch Health to come out to that person's house or office, whatever, before we leave. So that becomes the disposition. So instead of transporting them to an urgent care, we say, hey, you can stay here. We're gonna have urgent care come to you. And we've made those Dispatch Health referrals 48 times since we started the program. Now, it was very slow in the beginning because people didn't really trust Dispatch Health. They weren't used to it. They didn't know what it meant. And you'll see what we've done to help improve some of that over time. But the utilization of Dispatch Health is much, much, much higher. Interesting point. I don't know if you guys know this. I just learned this a month or two ago. Dispatch Health, national company, venture capital funded, very rapidly growing model. They're actually owned by Optum, which is a United Health Group arm. So it's interesting that the payer actually owns this intervention, this model, Dispatch Health. Pretty interesting. Okay, time on task. So we talked about the crews were concerned about that. We were concerned about that. So notice this is how we do this evaluation. So an AMA with telehealth completed takes about 58 minutes. An AMA without telehealth attempted, meaning it wasn't a Medicare patient or whatever, about 39 minutes. So it does take about 20 minutes longer to do the telehealth intervention. Part of that is the conversation with the patient, getting them to agree, then dialing or logging into the telehealth application, going through the telehealth process with the doc, calling Dispatch Health or whatever to make a follow-up appointment. But we feel 20 additional minutes on the scene is not terrible, and it's time well invested because the average task time for a transport in our system is 62.5 minutes, and you'll see that I'm sorry, for a transport is 75 minutes, but even doing the telemedicine treat and refer is 16 minutes less than transporting to the hospital. So when the crews are concerned about it's going to impact my task times, it's really not. If you do ET3 more, you're going to have shorter task times because you're not taking as many patients to the hospital. Therefore, your 75-minute task time becomes a 58-minute task time. So, oh yeah, hey, that's pretty good. So I'm going to do more of them because it shortens my task time. Now, I said that in the beginning, the uptake was relatively slow. And we realized that the online training and the things that we were doing, the reminders that we were sending out every week really wasn't cutting it, because there were a lot of people that just weren't doing it, and a number of eligible patients, and wasn't being done. So in our system, the Office of the Medical Director does a mandatory CE every quarter. Every field credentialed provider has to go through CE, including the managers and supervisors and even executives like myself who are field credentialed. We have to go through those CEs to maintain our credentialing. So at our October CE, we did a pretty significant face-to-face, no bullshit discussion about ET3. And we gave the field crews, each person who came through, a checklist that they had to initial in this column that says, yep, I understand the why, I understand the inclusion exclusion criteria, I know how to get consent and all that sort of stuff. And once they go through that entire process and they initial everything under the done, they have to sign under the penalty of perjury that they were present and they understand it. So, and I love this. I did not design this checklist. My counterpart designed this checklist. It says, I understand that I can call Desi, Matt, operations, whatever. Anytime if I have questions, feel free to call Matt Z after hours first. And they've taken that to heart. I get phone calls at midnight, 2 in the morning, whatever, with questions, and that's fine. Happy to help facilitate. But they sign this. So what they're saying is, yes, I understand it. I'm going to do it. And now we can hold them accountable that if they do not offer an ET3 model intervention for a Medicare patient who meets clinical criteria and doesn't have any of the exclusion criteria, it starts the corrective action process, because we really want this model to be the new model, because now we've got other payers that are paying us for the similar model, and it just makes more sense for EMS. It makes more sense for the patient, makes more sense for everybody. Now note this. So the training was finished on October 15th. Between just from through 11/7, we've had a 46% increase in the number of ET3 model interventions offered per day, and a 35% increase in the number of patients, miraculously, who are accepting the offer of ET3. Because now that the crews understand it, they know how to introduce it to the patient. They were just pencil whipping a lot of this and saying, yeah, the patient declined, patient declined, patient declined the offer. But when we would do the QA follow-up and call some of those patients and say, Kim, listen, Matt offered you the ET3 model intervention and you didn't take it, and you got a $500 bill in the mail for the AMA, and your Medicare is not going to pay for it because you didn't do telehealth. Did the crew explain that to you? And the patients, more often than not, in fact, almost every time, would say, they didn't offer that to me, and I would have taken it if they offered it. It's just, and the chiefs and the supervisors in the room and online are saying, oh yeah, I get that. And it's just, it's just pretty amazing. All right, I think we got another couple of fun signs here. Due to the quarantine, I'll be doing inside jokes, only doing inside jokes. Pretty funny. A perfectionist walked into a bar. Apparently it wasn't set high enough. Interesting. Documentation, one of the things that you're gonna have to do if you do this type of alternate disposition is change your EPCR, and in many cases your CAD, to be able to capture this data. We use ImageTrend here in our system, and Rick Hyatt, who's our health information manager, did an amazing job configuring our EPCR platform to be able to capture all of the data that we need to capture. Now, capturing the data is really important, because you need to know, was an alternate disposition offered? Did the patient decline it? Was it not offered because they didn't meet criteria? Whatever it is, because part of this deal is we send all of our patient contact data to Medicare every day. So every morning at 6 o'clock or whenever it happens, all of our patient care reports from the previous 24 hours get sent to Medicare, because they are using that data to evaluate the economics of this program. How often is it being offered? How often are patients declining? When it's offered and accepted, how often is the patient being taken to a different destination? How often are they being treated in place? Because that's some of the metrics that they are using to determine, is this model more cost effective for Medicare than schlepping all these people to the ER all the time? So appropriate documentation and careful documentation is a hallmark into this process. And then also, obviously, for the QA function, we want to make sure that we've got good documentation to be able to do the QA. So for example, ET3 alternate disposition was accepted by the patient. They did dispatch health. They took them to the clinic or they made a clinic appointment. The mobile crisis outreach team came out, telehealth consult and remain on scene, which is the majority of them. But these are just the example of the level of detail that we had to get into with our EPCR to be able to document all of this. Now, the reason for doing all of that, as I mentioned already, part of it was the Medicare data submission, but we can now pull data and we can do an analysis. And here's what it looks like. And I'm actually right in the middle of doing our weekly analysis this morning before I logged in to do this great program for you, or the great opportunity to do this program for you. I guess we'll know later whether you thought it was great or not. We pull this data. And these are all the times when the patient either AMA'd or could have been or was treated and not transported. So notice that when we pull this data, we can really do some good mining. So these are all the Medicare patients. Here was the dispatch EMD code. Here was the disposition. Here was, the telemedicine treat in place, dispatch health appointment, telemedicine treat in place. And we can really track this. And that's how we get the metrics. That's how we can do some good QA. If they had a Medicare patient who had, and you can't see it here, but that we've got other columns with vital signs, disposition, primary impression, secondary impression, and we can literally go through this and say, hey, Tim, you had 5 patients last week that met criteria for a potential ET3 intervention. Why didn't you offer it? Here's the 5 of them. Talk to us about these cases. And we're starting to do that because it is really important and we need that information to do that. One of the things to consider if you're going to do this type of a model with your partners is make sure that you've got some data exchange for them. So when we do a telehealth intervention, our image trend EPCR process is set up when the crew selects telehealth. A copy of that chart, when the chart is done, gets efaxed in XML, I think, over to IES, the telehealth provider, for 2 key reasons. 1, QA, 2, billing. Because we get the demographics and the insurance information on scene, we send that over to IES so that they can bill for the telehealth visit because it is reimbursable by Medicare and some insurers, and they do bill. Same thing with dispatch health. We send the reports to them and our clinic partner and our behavioral health partner. So figure out those interfaces because it is important for QA and tracking and all that sort of stuff. So our future plans, like I said, we've been doing it now since April, field testing it technically since October. It's working really well. The big thing is to apply it to more patients by getting more payers on board. And you'll see an example of that in a minute. We are unwilling to do it across the board when only one payer classification is willing to pay for it. As we said earlier, if we just start suggesting to all of the commercially insured patients that they don't go to the hospital and it jacks up our finances, we're in trouble. So we're not going to do that. Then we're really expanding that process, and the coronavirus helped us quite a bit. And I think a session later today, we're going to talk a little bit more about this, but we've gotten the payers' attention and they're starting to say, can we test some other models too? So let's do the ET3 thing or the whatever, but can we do a safe landings program? And all the things that you hear often about mobile integrated healthcare programs could be part of that. We're also thinking about bringing telehealth into the 911 center because in our conversations with some of the commercial payers, they've agreed, 2 of them, to pay for the response, not the transport, at the same rate as they would have paid for the ALS emergency transport to the emergency room on a 911 call. I think we have an example of that in this presentation in a minute. So we're going to get paid the same, whether we transport or not. Okay. And the payer may not, quite frankly, care whether or not we sent an ambulance, whether or not we sent a fly car with a single paramedic, sent a fly car with a single EMT to a infected toe, or can we disposition it in the comm center and not even send anybody? And that, nurse triage is a thing, and Medicare withdrew the nurse triage NOFO for very appropriate reasons. And what if a year from now, we get a 911 call and we do this today. So we're doing a 911 call and, the patient says, I've got an infected toe. The nurse says, or the call taker, the dispatcher says, hey, this is a 26 alpha 3. They don't say that to the patient, they say it to themselves. But 26 alpha 3 might be approved by the medical director for a telehealth intervention from the comm center. And the call taker says, hey, Kim, sorry about your toe, man. One of the things we can do for you, are you on a smartphone, Android, iOS, whatever? Oh yeah, I am. I'm gonna text you a link. And when I text you the link, click on it, and we're gonna connect you with a doc. And that doc is gonna walk you through some potential options. I'm gonna stay on the line just to see what's what. And they send the link, they click on it, and you do a telehealth intervention from the comm center. And after that telehealth intervention, the doctor says, Kim, listen, I'm gonna call in some antibiotic prescription for you, and you probably should go see your doctor, or you should probably, whatever. You don't need to go to the emergency room. We're not going to send an ambulance. Patient says, God, I didn't even know that was an option. This is super. Thank you very much. And what we are proposing to the payers, that intervention should get the same reimbursement as a transport to the ER by ambulance. It was a 911 call. It's documented it was a 911 call. Yesterday, we responded in an ambulance, convinced that patient to go to the hospital so we could get paid. We took them to the hospital. You paid us $1,000. You paid the ER physician $3,000. You paid the lab $400. You paid the hospital a $1,000 facility fee for the ER visit. Same concept. So pay us for the response, not the transport, and the response might be a telehealth intervention from the 911 center. And you know what? They're sort of saying, that makes sense. Let's do this part first, and let's see if we can get to, and that would be terrific. So we're looking at doing that as sort of the next phase.
Hey, Matt,
Yo.
We've got a question.
Sure.
Go ahead, Chris.
Yeah, no, I was just wondering, can you hear me, by the way?
Can you hear Chris?
Sort of, until you interrupted him.
No, I was just wondering, at what point does the telehealth provider say, wait a minute, we don't even need EMS, like this is our business model, and they actually get the revenue directly from Medicare to them, and kind of cut out EMS altogether?
Did you get that?
They're doing it now, right? I mean, watch television. Look at your Google ads when you do a Google search, or you go wherever. The telehealth providers have already started doing that. They said, and the payers are doing that, and they've been doing that part of it for years. That says, hey, if you have a concern, click on this link, or call our nurse advice line. They've been doing that for a long time. But because of the changing reimbursement models for the telehealth providers, and we didn't get into all those details, but under some public health emergency waivers, telehealth providers are being paid a much higher rate than they have in the past. The FaceTime, believe it or not, it used to be that you had to do an encrypted connection with an encrypted device, and it could only be from one healthcare setting to another. And all that went away last spring, or 2 springs ago now. So suddenly there's this plethora of telehealth providers that are willing to do this, because most insurers and Medicare and Medicaid are reimbursing it, and they're going direct to consumer and say, hey, scan the QR code on your TV screen, install our app, and at 2 p.m. when your kid has a fever, call us and we'll take care of you. So they're already doing it. And Chris, that was a great observation. But what they will never be able to do, well, never say never, what they will likely not be able to do is to undo 40 years of convincing people in your community, if you have an emergency, call 911. We can be the facilitator of the telehealth, and the telehealth provider is going to bill, and they're going to pay us a fee for that referral, perhaps, because the anti-kickback and the Stark stuff also went away, by the way, as part of the public health emergency waivers for now. Or the payers are just going to pay us directly for facilitating that, and they're going to pay for the telehealth, because again, when you take the ambulance payment, and even with the telehealth bump, it is still much cheaper to do that than to pay for the ER visit. But the telehealth providers are doing it now. They're going direct to consumer. Great point.
We have another question, Matt.
Sure.
Matt, you mentioned that the star clause and kickback stuff went away with waivers. Can you elaborate on that? Because that's been a challenge in our ET3 program. We were looking at doing it with our CP program with telehealth, and possibly having them pay us as part of the payment model to monetize it.
Yeah.
That's
So
a concern.
Yeah, absolutely. So there was a specific waiver, and Kim, if you remind me, send me a note in between sessions. I'll send you the actual waiver for the folks there. One of the waivers that they issued was the ability for physicians to do telehealth and to pay the provider that facilitates telehealth directly, and they included specifically in the telehealth waiver ambulance services. So, for example, IES, our telehealth provider, or pick one in Colorado, is doing telehealth, but the patient still needs to be seen, or they don't have a smart device, or they need tablet, whatever. They could call you on a non-emergency number and say, "Hey, Chris, listen, will you go to Tom's house and initiate a telehealth visit with me so that I can figure out what's going on with them? And if you do that, I'll pay you, $100." Okay, it's authorized under the waiver that says that they can do that. Similarly, there have been other waivers that have said that the OCR and the OIG are not going to enforce AKS and other things. And I think you've got Scott speaking later today, and he might have some more specific information on this. They're being very, very lenient, just like waiving HIPAA requirements. The requirement used to be for telemedicine, encrypted, store and forward technology, all this kind of stuff. Nope, you don't need to do that under the emergency public health waiver. You just do telehealth and you can bill for it and get paid and that kind of stuff. Some of those waivers, general feeling is, will stay and survive beyond the public health emergency, because Medicaid, Medicare, and the third-party payers are doing the math and saying, holy crap, the patients are getting better care, hospitalizations are down, managed care organizations are making record profits, because high cost utilization is down, because we've expanded this telehealth option, we've done all these different things. So let's keep it going. We kind of think this is kind of cool. And we need to capitalize on it as an industry. So, all right, I want to get to a couple of last points here before we run out of time. So this is a note, I think I said earlier, that just came out from Medicare Friday last week, that basically said, we know people are having a hard time implementing because of the transport to alternate destination thing. So we're going to amend the participation agreement for those that want to, that basically says we're going to delay the requirement for transport to alternate destination. You can implement a treatment in place program only for a period of time to be determined, 6, 12 months, maybe, whatever, to give people the option, the opportunity to vet those a little bit further and see how it goes. Between you, me, and the fence post, and I know we're being recorded, but I will deny I said this even when it's on the recording. My guess is at the end of the 6 months or 12 months, whenever this is finally might expire, I think Medicare drops the alternate destination requirement altogether, because they're seeing our data, they're seeing Northwell's data, they're seeing everybody's data. Well, not Northwell, they haven't started yet. They're seeing other data that says, 60, 80% of the time that we're doing an intervention in the field, the patients don't need to go anywhere. So just take transport to alternate destination out of the requirement, and it just isn't necessary. So I think eventually that goes away. I've got a call with our project officer tomorrow from CMS, so we're going to talk a little bit more about that. But there you go. Last signs. My friend David had his ID stolen. Now he's just Dave. That's pretty funny. If any of you know how to fix broken hinges, my door is always open. Again, kudos to the people that come up with this, or the person that comes up with that. It's just awesome. All right, Kim, I think we've got a little bit more time for some additional questions, and I haven't looked to see if there are any online, but feel free to, or whatever. So I'll turn it back to you to help facilitate that.
All right, thanks, Matt. We've got currently no questions online. Are there questions in the room? It's pretty quiet right now, so I'm guessing there may not be any more questions.
Would you be okay if naming those 2 private payers that are banned?
Go ahead, sir.
Would you be okay at talking about those 2 private pays that are willing to pay for the model?
What are the 2 private payers that are willing to pay?
And if he's not, I get it.
No, we can. You can talk about who, you just can't talk about how much.
Right.
Right. And then I think Asbel and Scott and everybody else would tell you that. So we dance this line pretty closely just to make sure that we're not doing anything poorly. So the Molina and Cigna are the most recent. There are several others. I'm sorry, I take that back. AmeriGroup is a third. And there are a number of other managed Medicare programs, and this has been a little bit unique. And I'm glad they asked the question because I didn't even think about this when I was preparing the presentation. When we do an ET3 model intervention and are billing the ET3 model HCPCS codes, remember we said that we're doing it for all Medicare patients. Most of our Medicare patients, not most, a lot, are fee for service, and a lot are managed Medicare. We are finding, and we're hearing this across the country, that even without a formal agreement with a managed Medicare payer, when we have billed the ET3 HCPCS code to managed Medicare, more often than not, and I mean significantly more often than not, they're paying it. And we thought, and sort of were told by Medicare, that we'd have to get individual payer agreements, because just because Medicare fee for service is paying for something, they were not mandating the managed Medicare to pay for it. And because they can't, or they claim they can't. I would argue that, and maybe Asbel would too, but they can't mandate it. But voluntarily, we had two managed Medicare payers enter into an agreement with us early. And they said, yep, okay, we're going to pay for the ET3 model intervention. That's great. Well, that covered about 70% of our total Medicare population. So we're willing to bite the bullet and roll the dice on the 30%. But even that 30% that we don't have agreements for, they're paying it because they understand the model, or they just haven't picked up on it yet, who knows. But they had to activate those codes in their system to process the payment. So it's worked out relatively well. We were able to get the state legislature to require Medicaid, including managed Medicaid, to pay based on the ET3 model payment scheme, not just for ET3 model participants, but for all ambulance providers in the state. They're working through that rulemaking process right now. So when you think about, the payers that are willing to do this, it's once they understand the math and the value that we can bring them that has nothing to do with a mileage fee, it's catching on pretty quick. Hope that answered the question. Maybe more information than you wanted, who knows?
Very good, thank you.
I remember that question. Matt, do you know anything about, I keep hearing from different people in the industry in Colorado, and some of them who I won't name, but that are high up in national EMS organizations, that they keep telling me ET3 is getting canceled, but I haven't heard anything about that from our model agent, or whatever you call them at CMS.
So we've heard that rumor as well, and that's part of the reason why I asked to meet with Alexis tomorrow. The email that they sent on Friday, and prior to getting the email on Friday, I would have been kind of on the fence that maybe they will, maybe they won't. The fact that they're willing to now go through the process to amend existing participation agreements to get more people to launch leads me to suspect that it's not going away. Now, I can almost guarantee you there will not be a round 2, and there will not be a round 3. Remember in the beginning, they said that, in year 2 we'll offer it again, and we might offer it. I doubt it. And part of the reason why, again, just my observation, I think, and we should ask Asbel and others this question as well. I think the mood of the payers and the mood of Congress and the mood of your state legislature is already moving toward payment for treatment in place as the new covered benefit. And we've got the national waiver for treatment in place right now from Medicare for any patient, as long as you've got a community protocol that allows you to do that. I think people have finally whipped out the napkin and took out their pencil and did some doodling on the back and said, holy crap, this is probably the better payment model. Therefore, the need for the ET3 model intervention becomes less pressing, because and I'll never forget this, Dan Swayze and myself and Brenda Staffen had the opportunity many years ago to meet with Patrick Conway when he was the director of CMS. And we were talking to him about, payment for community paramedicine and preventive care. And he said, we just need data, and it doesn't have to, and he said, we need data. We don't need peer reviewed data. You don't need to do a big study." He said, we don't need a peer reviewed randomized control trial study to know that parachutes save lives. Just give us some data that we can base a decision on about changing the benefit. That's all. And I think people are starting to understand that. And you've got commercial payers. Anthem, for crying out loud, back in 2016, started paying the AO998 HCPCS code across the board in all their Anthem states at 75% of the UCR for an ALS transport. That's been around for a long time. So I think the need for the ET3 model is going to go away because most payers are just going to start paying for the non-transport period. There you go. And
that was kind of our thought too. We felt like we were going to be surprised if it went for the full 5 years, because we figured somebody in a couple of years would go, well, duh, let's do it.
yeah, I think it happens federally next year in some legislation. And then there'll be some rulemaking that needs to go as part of that. But I think in your state, in Colorado, in Texas, and where we can where we can affect change even more quickly, it may happen faster.